All right, it is 10 o'clock and I am going to go ahead and we'll get started. I am Leslie Alsop at UNT Health Science Center, Safer Care, Texas, and I am so thrilled to welcome everyone who is here today. For the past 9 years, I have been working on the implementation of unassigned albuterol with schools in a framework to improve asthma outcomes that we term the Asthma 411 model. What I want to say about the privilege this has been is that we have all been facing such extraordinary challenges over the last 2.5 years. And in so many instances, the answers are unclear, the barriers may seem insurmountable. But in this instance, helping children to breathe easier and learn better is not that kind of a problem. Together, we can make this available to children across Texas, and the answers are there. So thank you to everyone who's making this possible. We have a participant with a raised hand. I just want to make sure that there is not any problems. I don't see any problems with people hearing. Please let me know if that's the case. We have a couple of points of housekeeping. And Rebecca, this is exactly, could you help me with this? There we go. All right, housekeeping. The webinar is recorded. Please enter any of your questions that you may have in the Q&A. We want to hear them. That will share them with our moderator. And of course, we want to clarify that the views and opinions expressed in the webinar are those of the speakers, not necessarily those of the views or positions of the University of Texas Health Science Center or Safer Care Texas, who are our hosts today. And with that, I have the great pleasure of introducing our wonderful national experts who I am so grateful are here today. I have followed both of these individuals and their work for the past several years. They have been a tremendous contribution to me. I've shared it with my students, and they are both authors of our national guidelines. Dr. Anna Volerman is an associate professor of medicine and pediatrics at the University of Chicago, where she is a primary care physician for both children and adults, as well as a health services researcher focused on improving systems of care and reducing inequities. At University of Chicago, she leads clinical, community, education, research, and advocacy initiatives focused on the health and education disparities. She has developed and implemented programs to reduce inequities in pediatric asthma, advocated for legislation and policies to ensure children with asthma can live, learn, and play like their peers in schools and their communities. I am also going to introduce Dr. Lynn Gerald, who is a University Distinguished Outreach Professor and Canyon Ranch Endowed Chair in the Department of Health Promotion Sciences, College of Public Health at the University of Arizona. She is also a scientist in the Asthma and Airways Disease Research Center. Dr. Gerald is an expert in pediatric asthma and school-based asthma initiatives. She has extensive experience in areas of clinical behavior, epidemiologic research, and respiratory medicine, and has served as PI or co-investigator on many NIH-funded research projects. Dr. Gerald has held several leadership positions in the American Thoracic Society, including serving on the board of directors, serving as chair of behavioral sciences and health service research assembly, co-chair of the membership committee, and co-chair of research advocacy. And with that, I am going to stop sharing my screen and turn it over to Dr. Gerald, who will begin our speaking today. Thank you so much.
Thank you, Dr. Alsop, and thank you all for having me. As Leslie mentioned, I've been working with schools for the past 20 years, and I really enjoy translating our research into public health policy and practice, taking the research and things that we find that really have an impact on children and figuring out how to make them into practice. And so I'm going to talk to you today about our experience in Arizona, going from the research that we've done into implementing a stock inhaler program. And so I want to start by saying I call this stock inhalers. It's the same thing as undesignated inhalers, unassigned inhalers. So each state's kind of calling it something differently. I'm probably going to call it stock inhalers because that's what our program is called here. So first of all, just to give you a little bit of background, as you know, asthma is a really common chronic condition. It produces these sudden episodes of breathing difficulty, which we call exacerbations. These episodes recur over time, and we don't often know when they're going to occur, even though there's a lot of triggers that may cause these exacerbations, respiratory infections, allergens, things like that. You know, asthma is potentially life-threatening. We have such good treatments now that people tend to forget that, but we do have deaths from asthma in children each year, and unfortunately, some of these happen at school. Asthma, at this time, asthma cannot be cured, but it can be controlled very well. And this is really, as I mentioned, since it's one of the most common chronic conditions in kids, about 10% of all school-age children have asthma. It's really an issue that schools need to deal with. It's the leading cause of hospitalization in young children. It's the leading cause of health-related school absences. And it also makes children have this inability, if they have poorly controlled asthma, to participate fully in school. They might miss class time, they might be in the nurse's office, or they just might feel good. You know, the Lung Association used to have this motto, you know, if you can't breathe, nothing else matters. And that's really true for kids. If they can't breathe, they're not going to be learning and they're not going to be fully participating in school. So some more of the impacts of poor asthma control. So this is when a child is not properly controlled, doesn't have appropriate medications, and they're having a lot of symptoms. It really impacts their academic function. Poor asthma control leads to significant sleep loss, which we know causes fatigue, poor memory recall, loss of concentration, and behavioral problems. So any of you that have kids or have worked with kids know that a sleepy child is one that has a lot of behavioral problems. So this is one of the things that asthma does to young children. And as I already mentioned, it really impacts their school engagement. But what's really important to know is that whether a child has poor asthma control or not, about 50% of children with asthma are going to have an exacerbation each year. And we don't know when these are going to occur. And because children spend so much time at school, we really need to make sure that they're well taken care of and that we know how to control these exacerbations at school. And these exacerbations, if not treated immediately, can lead to missed work and missed school and hospitalizations for children. So one of the ways that we think about asthma, so asthma really has two primary medications. We have controller medications that kids take every day for their asthma. And depending on the severity, not all children may have a controller asthma medication, but most of them do. But every child with asthma should have access to quick relief medication while they're at school. This is an albuterol inhaler that when the child has an exacerbation, it relaxes the muscles around their airways and allows them to breathe. And most of the time when a child has an asthma exacerbation, they can take a couple of puffs of this medication, rest for a few minutes, and they're able to go back to whatever they're doing. But they need to have this at school and school sanctioned events and at transportation to and from such events. So they need to have it at all times. All of our states in the U.S. have self-carry laws so that children can carry their albuterol at school. We encourage older students to self-carry and parents of younger children to obtain a second inhaler for school use. So sometimes young children don't carry their inhaler because parents are worried that they might lose it. But still, even though we have these self-carry laws and we know how to treat asthma exacerbations, respiratory distress is the leading cause of 911 calls and EMS transports from schools. So one of the things that we found in our research over the past 20 years is that few children with asthma actually have a personal inhaler at school. There's a lot of reasons for this, and it's not just among low-income children, as a lot of people think. It might be empty, it might be expired, it might be lost. Parents have to get a lot of paperwork to get that inhaler in school. So they have to go see a physician, they have to get an asthma action plan, and then they have to fill out paperwork and file it on school. And then sometimes obtaining a second inhaler can be costly. But what we found is that across the board, high income, low income, urban rural schools, less than 15% of kids actually have their asthma inhaler with them at school when they have an exacerbation. So this is a huge problem for schools. If a kid does not have an asthma inhaler when they have an exacerbation, what does the school do? Well, they can call the parent and ask them to bring medication, which obviously really wastes time when we are in kind of an emergency situation, or they can call 911. What is 911 going to do? They're going to come and they're going to give the child albuterol, which is exactly what was in that inhaler. So we really need to figure out how to have these inhalers available. I'm going to show you a video from one of our school nurses that talks about this problem.
Hi, Maria. So what's going on, sweet girl?
I can't breathe that well and I don't feel good.
Did you just come from PE? You did? Before the stock inhaler program, it was kind of a little scary because we would have students that were diagnosed asthmatics, and even though you try to reach out to the parents and call and try to obtain inhalers, sometimes they're having financial difficulties and they might not be able to provide an inhaler to the school and have one at home. So if there was a student experiencing respiratory distress, it was really just, okay, I guess we just call 911 because we didn't have any other option.
So a stock inhaler program, or undesignated albuterol, unassigned albuterol, allows schools to have a single short-acting beta agonist inhaler, which is the albuterol. They have this supply of these disposable holding chambers, and then they have a standing medical order and protocol to follow from a physician, which tells them how to administer this medication. This is really a very easy, very simple, very safe procedure that we can implement for schools that can actually save lives and certainly improves quality of life for children with asthma. So when I came to the University of Arizona about 15 years ago, I had a school nurse call me and she said, I hear you work with schools and I want to do a stock inhaler program. I said, that's great. I have no idea what a stock inhaler program is. So she told me what she wanted to do, and we decided to do a pilot study. And so before we had legislation, stock albuterol obviously is a prescription medication. You need a physician order to use it. And then without legislation, only nurses can follow a physician's order. So this school district happened to have a nurse in every school. There were 22 schools, 17,000 students. It's a low-income district here in Tucson where 85% of the kids qualified for free and reduced lunch. So we were able to implement a stock inhaler pilot study in this school district prior to our stock inhaler legislation. And what we saw really was amazing. We saw a 20% reduction in 911 calls and a 40% reduction in EMS transports, just in that one school year. Furthermore, we did qualitative interviews with school nurses, and they said it just greatly reduced their stress. They said, now if a child comes in with respiratory distress, we have something we can do. We don't have to call 911. We can give them a few puffs of medication and they go back to class. We are also able to use the stock inhaler to demonstrate the benefits of having it at school for parents. So it encouraged some to seek diagnosis. It encouraged others to bring their inhaler when they had not. And then students also told us that they felt immediate relief of their symptoms, and they knew that there was something that could be done for them if they had respiratory distress and wasn't sure where their inhaler was. So that pilot study allowed us to implement, to advocate to our state legislature and sign our stock inhaler for schools bill, which went into effect, which was signed on March 27th, 2017, and went into effect for the 2017-2018 school year. And our law allowed schools to purchase, store, and administer albuterol. It indemnifies school personnel for their good faith use and indemnifies physicians and pharmacists for prescribing and dispensing the medication. Very importantly, our law allows albuterol to be given by any trained school personnel to any student who experiences respiratory distress at school or school sanctioned events, not just the students with asthma. And Anna and I will talk to you a little bit about our experience and why the guidelines recommend any student with respiratory distress and any trained personnel and not just nurses. So after that, I was a little naive and thought we were done. We passed the law, great, it's going to just happen. But we realized that there was a lot of work to do in implementation. So I had a wonderful graduate student at the time that decided to take this on as her master's and dissertation project. And so we implemented the program, a stock inhaler program in all of the schools here in Pima County, Arizona, which is where Tucson is. And this just gives you an idea of what we provided to the schools. This is some instructional material. We provided the inhaler, and we provided a supply of these light air holding chambers. We had the standing medical orders, the protocol for use and how to use it, and then of course the documentation laws. So our signed standing medical order was signed by the county health department physician. He oversaw the program, but it can be signed by any licensed physician or nurse practitioner. And some of our schools already had relationships and they used that individual, but we decided to use a template protocol for all schools. And so this is what we found with our implementation in the first school year, 2017-2018. We had 229 out of our 340 schools participate, so 67% participation, which was not bad for the first year. And we estimate that 82% of our children in the county were covered by that participation. So most of the schools that didn't participate were small private or charter schools that we were unable to get in touch with. 66% of schools used the stock inhaler that first year, and we had over 1,000 stock inhaler events. So think about that. That's 1,000 children that had an asthma exacerbation and had no inhaler with them at the time. 80% of these events were in children with a known diagnosis, but this means that 20% of these events were in children that did not have a diagnosis. And what's important to notice is that 84% of these kids, after they used the stock inhaler, were sent back to class. We had about 15% that were sent home. Most of these were elementary school children. You know, an asthma exacerbation is a scary event, particularly for young children and particularly parents of young children. And then we had very, very few 911 calls and EMS transports that year, which was just a huge change. So there were about 7.5 events per 1,000 students. That's a pretty, significant amount of events. And we found that the use was not higher among any age group or any type of school. So public, private, charter, all used it equally, elementary, middle, high, and everyone used the stock inhaler equally. And then we also found that our program costs were about $125 per school. Let me show you one more video from one of our nurses.
Last year, so this is my first year at Continental last year, I had 6 911 calls. 3 were respiratory distress. I believe 2 out of the 3 students were known asthmatics, and they just either didn't have an inhaler here or forgot it at home. So we ended up having to call 911, and all 3 of the students were treated here. The paramedics treated them here with albuterol. I believe 1 student was treated, was taken to the emergency room, and the other 2 were taken home with parents to a physician's office. But it's really scary to be a nurse and to not have anything you can use on a student with asthma. It is heart-stopping. So the albuterol program that we started this year is phenomenal. We have had 0 911 calls due to respiratory distress.
And one of the most rewarding things for me about the stock inhaler program was that I got to implement it in one of our schools. And so my kid is a big band kid, was a big band kid, still is a big band kid. And I was the band booster co-president for 4 years. The largest high school marching band in Arizona. So we had about 300 kids in marching band, and I was the lead chaperone, which meant I was in charge of all the medications on and off the field. And so with 300 children, we had about 35 that had a diagnosis of asthma. And we were constantly having asthma exacerbations and having to call 911 because these kids didn't have their inhaler. And this is a high-income school district, which told us we have no need for stock inhaler because all our kids have one. So but sometimes they didn't know where it is. You can see these 300 kids, they all look alike. They have 300 backpacks that all look alike. And when somebody had an exacerbation, they'd say, Dr. Gerald, my inhaler's in my backpack. How in the world am I going to find that? So when we had the stock inhaler program, we were able to use that. And I'll give you one story. This is a competition we were at Northern Arizona University, which is about 5 hours away from Tucson. Our kids were performing on the field. The buses were about 2 miles away. After this performance, because we were in a different area where there's lots of different allergens, we have 5 kids in respiratory distress. So I was able to take the stock inhaler down there. 3 of these kids had a previous diagnosis. I said, "Where's your inhaler?" They said, "Well, it's on the bus. The bus is 2 miles away. That's not doing us any good." And then the other 2 kids didn't have a diagnosis of asthma, but all of the kids were able to use the stock inhaler and go right back to band practice. We didn't have to call 911. No one went to the emergency department. And the 2 kids that used the inhaler that did not have a diagnosis, we ended up being able to talk to their parents and physicians, and they got a diagnosis later. But this was their first time ever experiencing respiratory distress, which happens to a lot of kids. The first time they have it is at school. One last video.
So the sponsors who help put this in classrooms, in schools, have made a huge difference to, the 7, 8 students that I saw in those first 2 months whose families I didn't have to call and say, "I have to send your kid home, they're having a really bad asthma attack." We could say, "Hey, your student came to us and they didn't have an inhaler. We had our school inhaler," and we were able to care for them, and they're doing fine. And they're back in the classroom, but we wanted to let you know that, they had this happen today, they forgot their inhaler. Please remind them to bring it, but we've got resources here for them. That call as a parent myself, that feels good to know that that can happen in your school.
So I'll end with Anne's story. Anne is a layperson, but she is the principal of a large charter school here. And she really didn't want the stock inhaler in her school. She was a little bit afraid of it, but we don't have nurses in most of our schools here in Tucson. And so we explained the program to her, how safe albuterol was, what the state legislation required. She got her training, and Anne used the stock inhaler about 10 times in the first year. And so she's now one of our strongest advocates, letting people know how important it is to have stock inhalers in schools and how easy it is to be trained as a lay personnel to use the medication safely. So I just want to stop here, thank our sponsors. Here's my contact information, as well as a general stock inhaler email that we have here at the University of Arizona. Particularly a big thanks to Dr. Lowe, who was the graduate student and is now a faculty member that did a lot of this work. So I'm going to turn it over to Anna to tell you about how all of our experience led to some national guidelines.
Awesome. Thanks, Dr. Gerald. There we go. So good morning, everyone, and thank you so much to the group in Texas for the opportunity to be here and to share a little bit about the work that we've done in terms of national guidelines and implementation for unassigned albuterol in schools. So Dr. Gerald provided a description of the work that's been done over the last decade in Arizona, which really has been a pioneer both in legislation and programs for unassigned albuterol in schools. As you can see on this map here, there are 17 states that currently have legislation or guidelines that support unassigned albuterol, meaning that schools can have a supply of emergency asthma medication on hand to give to a student. As you can see, Texas is highlighted here, and a few years ago, legislation was passed that allowed schools to maintain and administer this medication. We'll talk a little bit more about the Texas legislation and the national guidelines as we go forward. So what followed, recognizing that these 17 states have regulations in place, we, led by Dr. Lowe, completed a systematic review to look at the states to really understand differences and similarities. And what I can tell you is, looking across, at this point, it was 15 states because it was at the end of 2021. There's several similarities across the different legislation across states. We know that states can have different regulations, and so there's opportunities to learn from each of these states and to think about what are best practices, which we'll share shortly. A few of the commonalities across states is one, just thinking about the inclusion of various types of schools. Another is the requirement for individuals to have training if they're going to administer the medicine. and then also providing liability protection for individuals who both dispense the medicine and also administer it in good faith. Here you can see that while there are commonalities, there are many differences. And in this table here, I've highlighted Texas for you, given that that's what we're talking about today. And so you can see going across here in terms of the school types included. Texas includes a variety of school types. Nearly all states have training requirements, although states vary on the specifics of their training requirements. And this is a place where Texas does not have any sort of regulations in place. Similarly, nearly half of the states comment on the types of devices that can be utilized. Another place where that is not currently included in the legislation. And then it's important to think about for unassigned albuterol that prescriptions are provided, are written by somebody, or dispensed by a pharmacy, and then are administered at the school. And so defining who those individuals are and ensuring that each of those individuals has liability protections is important in a place where Texas has included that information in their statute. Finally, in terms of medication administration, you can see that very few states require a guardian to provide permission before its use, and very few states require a prior asthma diagnosis. And this is where Texas varies from best practices. Further, Texas is one of 2 states that requires a nurse to administer the medicine. And then finally, you can see here in terms of mandated documentation and reporting that there are not currently requirements in place in Texas, which differs from many of the states. As you can see on this table, though, you can see that there's very few places is there a straight line up and down or across, and so there's quite a bit of variation. And as Dr. Gerald worked on the statutes and regulations and its implementation in Arizona, and I've done the same in Illinois, we came together to work on a set of guidelines. Now, in asthma, there's a variety of national guidelines, both in terms of the treatment of asthma, both in adults and children, and also its management in schools. What we did is we brought together a group of interdisciplinary team members, pediatricians, researchers, advocates, patients, pharmacists, and more, including parents, to help inform these national guidelines. As you can see here, these guidelines are supported by 4 national organizations: the American Thoracic Society, the Allergy and Asthma Network, the American Lung Association, and the National Association of School Nurses. So let's take a minute to walk through several key points of the guidelines, and we'll ensure that the resource is available for a more detailed read for those who want to. So first, in the guidelines, we talk about what types of schools should have unassigned albuterol. And the key piece here is that it's critical for children to have access to albuterol, regardless of what school they attend. And this is a point that's often forgotten in legislation or narrowly defined. Some may say that schools don't have significant oversight of non-public schools, yet it's really important to spell this out in the legislation, because for physicians, for nurse practitioners, for pharmacists, they need that legislation to both prescribe the medicine and to dispense the medicine, as well as to ensure that they are protected from a liability standpoint. Additionally, school administrators and their medical staff may benefit from that, from including a variety of schools, and in order to help them advocate locally for unassigned albuterol programs. So a second piece here is, a second key piece of the guidelines is who can receive unassigned albuterol in schools. And again, it is important for that medicine to be available to any student who needs it. So any student who is showing signs of respiratory distress, coughing, wheezing, trouble breathing, so on. Many children do not have an asthma diagnosis yet, or may not have forms on file. And why is that? The reality is, as a parent, I know how challenging it can be to get the right form, get it to my physician, my child's pediatrician, get it back from them, get it to school, make sure it gets to the right person at school, make sure it doesn't get lost in my child's backpack or their folder or their teacher's desk. Make sure it gets entered in the computer in the right place. And when a child is experiencing trouble breathing, the school is not gonna, it takes time to say, let me check in the computer if your child has asthma, right? And that's not time that we should be spending. So albuterol is safe. It is incredibly safe, and especially for children. And some students may not have documentation on file at school. Some students may not have an asthma diagnosis yet, and they may experience symptoms for the first time at school. And it is important that they have this medication available because it can be life-saving. The other piece is if we require parent authorization, we are again restricting who can receive this life-saving medicine, right? It's, you know, we don't require authorization for children to have an EpiPen if they have allergies. We don't require parent authorization for somebody to use an AED if their child stops breathing and their heart stops beating. So why are we limiting this life-saving medication and the access to this life-saving medication for children? Another key piece is just thinking about where can this medicine be administered? And so it's important to think about the school, right? And there is the school and the school day, but there's a lot that happens at school that is outside of the hours of the specific school day, right? Whether they're 8 to 3 or 9 to 4 or 8:30 to 2:30, whatever it is. There's often before school, there's often after school. Schools take field trips, and there's often sports and extracurricular activities that children are participating in. And so it's important that unassigned albuterol is available to students anywhere on school property or at any school-sponsored activity or event, and not just limited to the specific hours that a certain person is there or that the office is open, per se. So getting to this next piece about who can administer unassigned albuterol. In the national guidelines, we recommend that the medicine can be administered by any trained school personnel. Currently in Texas, it says that unassigned albuterol can only be administered by a school nurse. And I wholeheartedly believe that school nurses have an incredibly important role in the school building. However, they cannot be alone in the individuals that have access to this medicine and who can provide access to that medicine for children. In many places in our country, including in Texas, there is not a full-time school nurse in every school. In fact, based on numbers from 2019-2020, there's an estimated 6,000, just over 6,000 school nurses in over 8,000 schools across Texas, with a ratio of 1 school nurse for over 1,100 kids. And so if the school nurse isn't there, that means a student who's having respiratory distress cannot receive the medicine. And this is a limitation that's unacceptable. It is important to acknowledge that individuals who can administer this medication should have training so that they can recognize signs of respiratory distress and they're prepared to act. And this training can vary. It's important to be flexible, to allow both in-person and remote options, to provide a recorded option. For example, if somebody starts in a new school mid-year and want to be able to provide that training, and also to ensure that sufficient staff are trained, right? So if you have 1 person trained in each school, what if that person's sick or on vacation? So we recommend a minimum 2 individuals are trained per building, and especially since some schools can have more than 1 building, and with consideration given to additional individuals based both on what is the prevalence of asthma at the school and also other school indicators such as the population, how many students are in that school, how is that school laid out. It's also preferable to train as many individuals as possible and that are to ensure that there's a trained individual every day. And finally, I would recommend, and in our national guidelines, we recommend considering parents, caregivers, volunteers, coaches as additional individuals who can receive the training, because we know that these individuals play a key role at various school-sponsored events like field trips, like sports and extracurricular activities. And so they can be additional individuals who are trained and prepared to act to help a child. There is in some of the legislation, there has been a focus on which types of devices can be utilized. And in our guidelines nationally, we recommend, this is a point of debate in full honesty in terms of the effectiveness of both inhalers with spacers versus nebulizers. And I will say that both are incredibly effective. So an inhaler with a spacer or a valve holding chamber works just as well as a nebulizer. And in fact, the inhalers are more portable. They tend to have less side effects. And they, particularly with COVID, the inhalers are preferred over the nebulizers. In terms of the legislation, it's reasonable to leave it open to both, but just in terms of implementation, the inhalers with valve holding chambers or spacers tend to be more practical, more beneficial, and more readily available, both in terms of cost and portability. Another piece that we address in the national guidelines is how to prescribe and procure the unassigned albuterol. So it's important to include standing prescription orders to ensure that schools can receive the unassigned albuterol, and consider the pharmacy dispensing laws and how they may affect schools being able to obtain the medicine. And finally, funding is a key piece for such programs. In addition, standardized protocols can be beneficial for trained personnel to use that provide clear instructions about how the unassigned albuterol should be administered, how much, how often, and what should be done in various cases. And then in the guidelines, we talk about what should happen after unassigned albuterol is given to an individual. So during the event, it's important that a parent, guardian, or emergency contact is notified that this has happened. Obviously, addressing the respiratory distress and the symptoms that the child is having come first and foremost. But it is important to speak to that family member. Our goal, and as you can see with Dr. Gerald's data from Arizona, unassigned albuterol is quite successful in helping get children back to school. And thinking about this from an education standpoint, that's really our goal, right? To keep our kids healthy and to keep children healthy so that they can stay in school. Calling 911 should be part of an algorithm or a pathway. If a child is having significant respiratory distress, their lips are turning blue, they're not able to talk, or if the unassigned albuterol has been given and has not been effective. But it should not be a required part of the pathway, because our goal, again, is to get children back to school, back to class, and or home if needed. And then after the event, it is important that there is documentation of the event and the medication that's been administered. And this is important both for monitoring for the child, right? If this is an event that's happening weekly or every other week with a different staff member, it's important that that pattern is noticed. But it's also important for monitoring such programs and adapting them and making changes to make sure that they are staying relevant and most applicable and safest for schools. And finally, it's important to follow up with a parent or caregiver after the medicine's been administered to ensure that the child is either evaluated for asthma if they haven't been previously diagnosed, or that any adjustments are made in their medicine if they have a prior diagnosis, and that reminder is given to ensure that that child has medication available with them both in and outside of school. So taking a moment to compare Texas and the national guidelines, you can see that there are some key differences between the current legislation in Texas and the national guidelines. And this is really a piece that we were asked to specifically talk about and to point out these discrepancies. And these are recommendations, our recommendations for what should be amended in the Texas legislation to align with best practices and to ensure that children in schools in Texas are receiving the most benefit possible from this unassigned albuterol program. Just some last points. Albuterol is safe and has the potential to be life-saving. Every child should have access to it in case that they do experience respiratory distress. And the regulations and the statutes put forth in Texas should be designed to really empower trained personnel and to reach children broadly. Thank you very much. My email is on here, so don't hesitate to reach out, and I will turn the screen back over.
All right. Terrific. I hope everybody is now able to see the slides, and I'm going to just take a moment. We are so grateful that Dr. Gerald and Dr. Volleman can give this fabulous overview of both their expertise and the national viewpoint and where we're situated with that. This next portion, we're going to talk a little bit more about what we've been doing in Texas, what's available in Texas, and what some next steps may be. Then we'll have finish with a question and answer panel. So please do consider asking some questions, entering it into the Q&A at the bottom of your screen so we can address those. We are going to go ahead and I will start this next portion. So we are, I want to introduce our speakers here in addition to myself. First of all, I want to introduce Dr. Afolabi and Dr. Falashade Afolabi is a pediatric pulmonologist. She will be our forum moderator for the remainder of our presentation, especially during the Q&A session. She is an associate professor of pediatrics, has published widely on pediatric lung disease, and is an active member of the American Thoracic Society, the Texas Medical Association, and the American Academy of Pediatrics. And I want to especially thank Dr. Afolabi for reaching out to me and initiating our task force, jointly initiating the task force and forum events. It's been tremendous that we are able to have this wonderful community coming together. I also want to introduce Charlie Kagan, who is Director of Advocacy for the American Lung Association in Texas and Oklahoma. Charlie Kagan is, he has spent the last 7 years empowering and working with communities to address the toll of tobacco and cancer. Previously for the American Cancer Society Action Network, he has worked on numerous local smoke-free campaigns, helped lead efforts to pass Texas Tobacco 21 law, and has also worked to pass several ballot measures to increase access to health care, including the Cancer Prevention and Research Institute of Texas renewal in 2019. He lives in Austin, Texas with his wife, dog, and 2 cats. So I am going to go ahead and take a quick snapshot very quickly of some of the work that we have done in Texas, and especially with the Asthma 411 initiative. Asthma 411 as a model actually goes back to 2002 to 2008 when the CDC supported the Controlling Asthma in American Cities program. And it was a comprehensive model. It was shown to reduce the attendance gap between children with and without asthma, to reduce EMS calls, and to increase the number of current asthma action plans that have been completed by healthcare providers. It has included unassigned albuterol within a framework that supports asthma outcomes improvement, including education, professional development, and of course, links to resources. Now, lots has changed since 2008. We do continuously review this and national guidelines to keep this up to date, but those basic 3 elements have continued. In 2013 to 2015, we started a adapting the model to North Texas. We had a 2-campus pilot for 2 years. One of the outcomes there, those 2 campuses had had 19 EMS calls 1 year prior to our pilot implementation. During the implementation, there were no school day EMS calls made for 2 years. There was only 1 EMS call made, and it was after hours, which touches on a point that Dr. Gerald and Vollerman have made. It was an after-school sports event. The nurse wasn't there, and there was nobody who had access to the albuterol at that time. We also had good promising results that, although it was a small study, that we were reducing the attendance gap between children with and without asthma. And when this was shared with our county judge, he charged our 3 partner institutions, the UNT Health Science Center, Cook Children's, and the JPS, which is our county health and hospital network, to make this available to reduce barriers for any school district that would like to have this product and implement the program. So we continue to have the Asthma 411 consortium between the wonderful entities that are listed here at the slide. And today there are 11 partner school districts who have adopted it, 370 campuses, over 250,000 children are enrolled. So I'm just going to touch on a little bit of our the evaluation data that we have. I'm looking here. This is actually, should say 2020-21. It is the last year before the full implementation of HB 2243 and its regulations. During 2020-21, you'll note that this, of course, was very disrupted in terms of the COVID pandemic. So only 7 of our 11 school districts that year implemented the program for at least 4 months. And of those, we had 477 reported uses. The mean age of students was 9.5 years. That's been very constant for us. A full age range needed this medication at some time from 4 to 18, but the majority of students requiring the medication were in this 7 to 12 year age group. In terms of our disposition, very similarly to what Dr. Gerald showed, just over 80% of children were able to safely return to class. Just under 20% were dismissed to their parents with a request that they receive healthcare that day. And on that, we had 0.2% of kids receiving treatment were reported to require EMS transport. Only 1 EMS call was reported. So I want to speak also very briefly about some of the resources that have been developed through this initiative and some of the results from our school health surveys. At the end of every year, we have sent out a survey to school nurses, and I am again showing the 2020 to 2021 because that is the last year we had before the new regulations were put into place. Regulations came in toward the end of that school year, not during the entire year as they are currently. So we sent out our survey to 7 districts that had 176 campuses and a strong response rate. I'll get into those details if anybody is interested in the survey. But I pulled out these 2 questions because they address some of the concerns I've heard repeatedly when a district or school is considering implementation. And this first question is, are nurses going to be okay with this? Nurses are already so busy. They're doing so many things. They can't possibly take on 1 more. We have found that 97% of those who had used the program indicated they were satisfied or somewhat satisfied with the program. And we've had many overwhelmingly positive comments and stories similar to the wonderful in-depth qualitative reports that Dr. Gerald has presented to us. Another concern that people have is that parents or families are going to object to the fact that someone is going to administer medication to their child in school. In fact, we have found the exact opposite of that. With our survey consistently, nurses who have received some type of parent-family feedback, say 97% is positive or somewhat positive. And when people are unhappy, almost always it's because there was some barrier in being able to provide the medication when the child needed it. The greatest challenge that we have had, and we began to see this, of course, at the end of 2020-21, when the legislation was put into place, the fact we had to have a form completed by the parent ahead of time. And I'm only presenting that one comment, but we have seen it repeatedly. And as we begin to look through this year's survey, this is only escalating now that it's been in place throughout. However, again, overwhelmingly, this has been positive received. One quote, an essential program that meets a real need in our public schools and has been very beneficial for me and my students. I want to just point out, we do have the Asthma 411 website. We have many tools for implementing, and although we developed this in conjunction with our partners here in Tarrant County, they are available to anyone in the state of Texas, and they are specifically designed to implement and respond to whatever legislation we have. This includes an online training program that provides one free contact hour to anyone who takes it. People could go online now and look at that if they want to. I am very happy to say that our consortium has two pediatricians from each of our 3 consortium members, and they have provided medical review for us. They meet quarterly to do so. And I also want to thank Dr. Afolabi, who's taken a look with our CEU as well. I'm happy to say Safer Care Texas, which is where I'm based, is a state-supported patient safety initiative at UNT Health Science Center. And they have taken the lead in constructing this. And we are now on our 3rd iteration of the CEU, because with the COVID, with legislation, we have always worked to keep it up to date. Should we be able to make adjustments that bring Texas legislation in line with best practice, I understand Safer Care Texas will again be willing to step forward and work with partners to bring together training material that would be online and available to all. So just reiterating what Lynn and what Dr. Gerald and Fullerman have mentioned, who can receive the unassigned albuterol. In Texas currently, a student who has a written statement from a parent of an asthma diagnosis and written permission. And there are many times where this is an enormous barrier to kids. I'll just tell one quick story from a recent health fair. I had a parent who said, wow, I love your program. I wish that my child could benefit from it, but you know, he's taken albuterol for a really long time, but his primary care provider says she's not sure whether he has asthma or not, and I need to go to a pediatric pulmonologist for the diagnosis to be confirmed. And so the school asked me, does he have asthma? And I can't say he has an asthma diagnosis. That's an enormous, and there's so many children, of course, who don't have access to healthcare and may not have that diagnosis or understand that their child has a treatable condition. The written permission, many of our districts prior to this requirement being put into place obtained written permission by putting information about this in their policy and having parents sign on to their this with their school policy annually on enrollment, essentially opt out. However, school districts said that if it's not available to everyone, if it requires a report of an asthma diagnosis, they can no longer obtain permission as part of their code of conduct and their annual enrollment. So these two can really go together in terms of surmounting the barrier. Who may administer albuterol? Currently a school nurse, and eloquently address this concern. Where may it be administered? Currently only at a school campus. Again, we've had parents who have said, this is a lifesaver to know that I may not be able to get the inhaler to school, or my child may miss it, but if they're at the zoo, if they're out on a field trip, if they're doing some environmental project, I know that they can have albuterol there. It is such a peace of mind. Implementation consideration that we have found: professional development and training is key. We want to keep our current adaptable tools available to everyone, and ensure that this includes the appropriate follow-up. There are documentation and reporting requirements in Texas. I think these can really be streamlined. We have developed some tools to try to help with this, but again, I am seeing in the surveys, our preliminary review of surveys can clearly show that nurses are frustrated. A comment that comes to mind: I can't do this anymore. I now have too many hoops to jump through. And then I'm going to stop sharing, and I am going to ask Charlie Kagan and the American Lung Association to please go forward. Charlie?
Thanks, Leslie. And you can actually keep your slides up if you like.
Oh, I'm so sorry. You're right. That's the
no
plan.
problem.
I apologize.
Hey, folks, my name is Charlie Gagan. I'm the Advocacy Director for the American Lung Association. The American Lung Association is focused on improving lung health and preventing lung disease. And when it comes to stock albuterol, the evidence shows that these quick relief medications are not only effective for respiratory distress, but they're safe for children. And therefore, access to schools is critically important to improving outcomes. And so, as Leslie and Dr. Vollerman have already mentioned, Texas has already taken some action on this. Back in 2019, several partners on this call worked to allow schools to stock albuterol, to stock unassigned albuterol. And they put that in the code with epinephrine. And so that is a big help moving forward, that asthma and epinephrine are already in the same legislative code and statute. But in 2021, there was continued efforts on this issue. A bill actually passed the House near unanimous support, but ultimately ran into a deadline in the Senate. So we are optimistic that 2023 will be the session that we finally get this across the finish line. And really, while there are obviously multiple aspects of this policy that can be improved, our main policy goals are: number one, to ensure that any student experiencing respiratory distress can receive albuterol; to ensure that every school, whether they have a school nurse or not, can train personnel to administer albuterol; and that there is annual notification for families, but no requirement for a waiver. Again, this is a safe medication, and we want to make it as easy as possible for that school personnel to administer the albuterol quickly and efficiently. Go ahead, next slide. So I wanted to give you all just a quick preview of what the legislative process is going to look like and how you can help start taking action today. So we have been working with stakeholders for the past few months, and we'll continue into the fall to work with lawmakers and shareholders to build the legislative language and get our draft bill. And we've already had good conversation. Representative Stephanie Click, who's the chair of the Public Health Committee, ran this bill last session. We've had some good conversation with several senators in the North Texas area. So there is definitely interest from lawmakers in addressing this common sense solution to save kids' lives. The legislative session will begin in January. We expect sometime in the early spring for the bill to be considered in the relevant committees, whether that's the Texas House Public Health Committee and the Texas Senate Education Committee. And then at some point, once the committees have reviewed and approved the bill, the state House and state Senate will vote. And then in late May, early June, the governor will take action. He actually doesn't have to sign a bill. He just can't veto it. The bill will go into effect either late September or January 2024. And so obviously, we still have a lot of time in front of us, but what you can do today to help us as advocates and help us as educators is to sign up for alerts and share your story. And so this is a great way for us to communicate with you all if you want to stay updated on our efforts and on this initiative. And it's a great way for us to identify folks who have good stories to share, because, you know, Leslie and I can go in with all the great data and case studies, but it is those personal stories of a parent whose child was saved by albuterol, or a child who has experienced you know, an asthma attack or a respiratory distress in school, and how important it is to have that quick, easy access. So I'm going to drop a link in the chat box for you to sign up for that. And of course, we'll send it out with our follow-up information. But just again, thinking down the road, if you'd like to get more involved, if you're someone who's able to travel to Austin with little notice and speak at one of those committee hearings, or if you're someone who is able to call and email your lawmakers regularly, those are all ways that you all can help us make an impact in the Capitol and with lawmakers to make sure that this is a top priority from them. So I'm going to drop the link for you to sign up for alerts and share your story. And I'll go ahead and hand it back to Leslie or Dr. Afolabi.
Thank you so much, Charlie. We are so grateful for the work that you do and that the American Lung Association does to try and address the policy. And it's such an extensive process of networking. We're so grateful for you in taking that on. The panel today is going to be moderated by Dr. Afolabi, and I'd like to go ahead and turn this over to have her begin to take this as soon as I go ahead and introduce the two additional panelists that are going to be joining us from Texas today on our Q&A panel. And first is Dr. Harold Farber, who is Associate Medical Director of Texas Children's Health Plan. He serves as a pediatric pulmonologist at Texas Children's and is a professor of pediatrics, Baylor College of Medicine, and his research interests include clinical, epidemiologic, and healthcare delivery quality improvement. Dr. Farber serves as a co-investigator for the Baylor College of Medicine site of the American Lung Association Asthma Clinical Research Center Network, and he is a leading asthma care. He is leading the asthma care quality improvement efforts for the Texas Children's Health Plan. I'm also very happy to introduce Rebecca Delaccio Baisley. She is a school health administrator from one of the Asthma 411 partner school districts. She has partnered with the Asthma 411 Consortium in 2018. She is a registered nurse for over 25 years, and her experience with acute and chronic medical conditions and focus on wellness has brought her a fulfilling career in school health. She currently coordinates training and ensures compliance for the campuses in Northwest ISD. And in addition, she constantly looks for opportunities to enhance the school nurse's role as a case manager and community health expert. So with that, I'm going to stop my share and let's see.
Hi, good afternoon, everyone.
Thank you so much, Dr. Afolabi.
So I encourage everyone to click on that link in the chat, even if you don't have a direct commentary to give or a direct direct comment to give. We would love to see you register and hear a little bit more about what your opinions are about this legislation. We're going to get right into the meat of it. I had a couple of questions, but it looks like Dan Dean has a really interesting question, which I think is probably the heart of what our questions typically are. And I think we can direct this question actually to all of the panel because it's so important. I'm concerned that documentation of asthma in known asthmatics is a problem obtaining from physicians. And we've discussed this already. The asthma action plan is a requirement for management of asthma, and every known asthmatic should have one, which doesn't always happen. He didn't say that, I said that. Have there been attempts to address this at the Texas Pediatric Society annual meeting? This would inform pediatricians that there is a communication problem, which may lead to corrective action.
I'm going to just jump in really quickly and then open it to everyone else. We would love to work more with the Texas Pediatric Society and communicate with this. So if there's someone on the call here who we can reach out, but I would love to make that connection. I want to take hats off quickly to Cook Children's here and Dr. Vida Amin there, who implemented a process in their EPIC system, which we know putting anything in the electric health record is so hard, to include the asthma action plan along with the medication authorization, severity, and critically permission for the prescriber, the physician, and the parent to discuss, and nurse, to all discuss together the child's condition. And it's our hope that is aligned with this national guidelines that Lynn and Anna and others have put together for these asthma action plans. We're thrilled, and we hope that that can help put together that circle of care that we know is so critical for any child, but especially one with a life-threatening condition.
The other part of this is that this will then make a child who's needing a lot of albuterol, that will bring it to the attention of the school personnel. So that the school person, you're coming in every day, several times a week for albuterol. Hey, something's going on. Now the school personnel will be discussing it each time with the parent, and then can start to coordinate with the medical care system, as opposed to a kid who's just carrying it in his backpack and using it all the time. The other thing I want to bring up is that even when the child is authorized, has all the signatures to carry their albuterol, what school nurses tell me, and you guys who are school nurses can confirm this, is that when the child is having asthma problems, the albuterol inhaler is at home.
Exactly.
Yeah.
That's a challenge in the school setting for sure. And that's why we love having the what we call the unassigned albuterol there.
The other thing is that occasional albuterol is normal, is low risk, isn't going to hurt a child. And if a child who doesn't have asthma gets albuterol, it doesn't make any darn difference for them. It's not going to hurt them.
A key point, I want to thank you both, that we emphasize in our training and in our CEU, and I think it's very important to have it. We must ensure that children get the follow-up for all of the reasons that Dr. Farber has just mentioned, and we can put that into our training programs. We emphasize, what does the asthma control test tell us? Should be that flag if they're using that albuterol too often, how to communicate about that and to ensure no child is ever dependent on albuterol that's at school. That's one of our mottos that we repeat over and over again. Thank you.
So I had a couple of other questions for Ms. Basley. I hope I'm saying your name right. So what are some barriers that school nurses face right now? I know that Dr. Gerald and Dr. Volleman talked about that quite a bit, but in your experience, actually kind of on the ground and implementing this, what are some of the more difficult barriers that you feel that school nurses are approached with at this moment?
Well, they did hit on two of the big barriers, which are that we currently need a diagnosis and permission from the parent to give the medication. So I thought, since everybody understands that, I'll just say real briefly that we have tried to address that with electronic medical records and electronic registration so that we can get online really quickly and confirm that the person has a diagnosis. But I know that's not the case for a lot of districts where they may not have electronic medical records. They're filing through an old-fashioned file to get that diagnosis. And that's where the legislation changing would help them. They don't have to worry about spending 4 or 5 minutes trying to figure out if the student has a diagnosis. They can just go ahead and give the medication and then reach out to mom or dad and say, hey, I had to give it. Let's work on getting some additional care here. Another barrier is the delegation, not being able to delegate it to a non-clinical person right now. And we hope to have that addressed as well. There are a few things that can be assigned as an assignment to a non-clinical person, even though the nurse is not delegating, and then it relieves the nurse of having the responsibility on her license or his license. But also, it's kind of up to the school districts to look into that and see if there's a way around some of these barriers right now.
Thank you so much. I had another
Can I make a comment on what
Go ahead.
Rebecca said?
Of course.
Yeah, I think this is really interesting because I've been working with states around the country. And so one of the big concerns from school nurses is that this is something that is tied to their license, to their ability to delegate to somebody. And that, is the purpose of the legislation, is to unlink it from the school nurse. Not to say that the school nurse is not incredibly important, and she is the one that usually is involved in the training and deciding who might, but that it's no longer the school nurse's responsibility, that once an individual has been trained by whatever mechanism the state legislation says, then the school nurse, it's not under her license anymore. And so I think that's very important for school nurses as well, because they're already overwhelmed and have so many things.
And that's exactly what's happened with epinephrine, and it should happen with albuterol as well, that the person can be trained. They show that they're proficient, or they can give it without problem, and they understand, what to do afterward. And just like you said, it then relieves the nurse of having to worry about, well, my license is at stake here if I have this on my campus.
Another question I had for you is, and once again, I think that everything was covered really, really nicely in the talks, but what types of schools, specifically in the state of Texas, would benefit, do you think, most from this type of legislation change?
I think one of the doctors said every school across the board would benefit from this. But again, those schools that are in the rural areas where there's not a nurse at every campus are especially going to benefit. And those schools that are not able to afford electronic medical records or electronic registration are going to benefit the most, because currently they have more barriers than everybody else in implementing this. So they're really going to be the first ones to benefit.
And if I may go back just a second, as we were talking about licensure issues, I recall early in this process, as our committee was talking, we had heard about one state where a child was having a very severe, life-threatening asthma exacerbation. The nurse administered albuterol off-label, not authorized from what they had in stock, saved the child's life, but was disciplined, lost her job, because she saved the child's life without having all the right papers signed.
Yeah. So I think that this is really important legislation. Another question was, for people who've implemented this in their area, how do you get buy-in from districts who don't have a nurse? We've seen that the school nurse can advocate for having it in their schools, but reaching out to schools without a nurse seems to be a challenge.
So let's just
Go ahead, Leslie.
I'll speak just really quickly to Texas, and then Dr. Gerald, I'd love to get that important expertise nationally. We have a variety of districts. We have 11 different districts, and we are fortunate most of them do have school nurses. We have one district that has only one school nurse who's a licensed RN and works otherwise with health assistant. It's been very, very hard. Obviously, they were incredibly impacted by this. But I do think that districts, if we can get this legislation in place, and we have those tools that are available, we can support and make it much easier to implement. I think what's really tough currently is that it just says a district should provide the training. A district should come up with their documentation and all of their, this is such an incredible burden. I will say that in districts, irrespective of their staffing pattern, they have seen children struggle, and children struggle to breathe and not be able to help. And once they understand that they've got the ability to do this and their tools, it was not a problem to get their buy-in. Thank you.
Yeah, and I'd just like to follow up to say, you know, I've been in most of the states that I've worked with don't have a nurse in every school. But every school has some mechanism for administering medications to kids. They have to, whether it's the principal, whether it's the front office clerk. And so that is the person that we need to, you know, to get to for stock inhaler programs where you don't have a nurse, because that individual has likely seen an asthma attack. And they're the one that's kind of responsible for health. And the last video I showed you of the principal from our charter school, she was very nervous at first because she's seen a lot of asthma attacks, but she didn't really know how to use an inhaler. But she was the one that we reached out to, and now she's the biggest advocate because she said, this isn't that hard. And I think you have to realize that every parent is a lay personnel and they have a child with asthma, and we teach them to use inhalers, and it's incredibly, incredibly safe and easy thing to do.
There's another question, and I was going to ask about this for those who've implemented it. Where can we find data on the cost of using stock albuterol, and when we're pursuing this, and data can be helpful in establishing a plan?
Dr. Gerald has terrific information about that, but our Asthma 411 consortium also has information where we've estimated. I think that it's, you know, our actual estimate is probably considerably lower than $125 per campus once you get going. Much of it is setting up this infrastructure and kind of that in kind. And that's why I think what we've been able to do in terms of developing adaptable tools can be very, very helpful. Just think, I believe we can get into this point, thank you, that if you have allowed one child to prevent calling EMS, how much you have done cost savings have exceeded the program for that year. And we have so many people who have said, I don't have an extra inhaler, I'm worried about my child going to school today, and so I'm keeping them at home. You don't need to avoid very many absences to make this program pay for itself. And I would highly support cross-sector collaborations as we've had. I think much of that is very replicable to other areas. And thank you for this wonderful chart.
Yeah, absolutely. To follow up on what Leslie said, as she mentioned, you know, most really the only thing you have to have is the albuterol and the light airs, which you can see our cost of $125 per school was largely driven by, we had a half-time staff position that was in charge of coordinating this. I think it was well worth it. So it's still very inexpensive, but a school can do this themselves, you know, around $50 to get started. I think the other important that Dr. Alsop mentioned was husband's a health economist, so we always look at these things and look at the cost savings. And you know, I'd like to point out that Illinois is the first state to actually fund stock inhalers for all of their schools, partially due to Dr. Bolerman's advocacy. But we've been able to get some of our county health departments to sponsor it for each county, because this just gives you some estimates. Say we reduce 911 calls by 20%, ambulance transports by 40%. As we saw in our pilot study, Dr. Alsop's had even better, you know, success with that. We, you know, for our county alone, we'd save $130,000 a year, but for the entire state of Arizona, you know, it's $900,000 a year, and that doesn't include parental missed work time or child's missed school time. So I think, you know, this is our next step down the road, is to try to get some funding for this, because albuterol is incredibly inexpensive and can save lives. So I think it's worth thinking about.
Dr. Gerald,
Yes.
while we're on the cost savings, what about the benefits that will go directly to the schools by having increased children attending? You know, how many days of increased attendance do you need to offset this cost?
Yeah, I think definitely.
They're about $30 a day in Texas. And so we have done some estimates where we have had data sharing agreements. We can show across the board, kids with asthma have a statistically significant increased absenteeism, increased chronic absenteeism, about 2.5 days excess absences per child. And if you're applying that, as Dr. Gerald has talked about, where you've got 10% of kids with asthma, the cost of that is enormous. Not all of that difference may be due to asthma. We can't do that attribution, but asthma is a modifiable risk factor. And so we know that's something we can change and we can help with. And I think the cost saving there is enormous. We've done some work on it, and we need that health economist and will to partner.
So I think that we're nearing the end of our hour and 15 minutes of this talk. I think it's been absolutely amazing. I think we've had some wonderful education and engagement regarding improving access to stock albuterol to children in Texas. I actually am going to go a little bit time over because I had a quick question for Dr. Sexton, because you have some experience with, I know, sorry, but you have some experience with being a physician delegator. And I wanted to know, did you find that experience to be cumbersome or to be challenging now?
Well, I just unmuted myself. So I honestly, I think that what has made, well, one, coming in, so I'd have to give major kudos to Dr. Haynes, who was a prior delegating physician consultant for the school, for our school districts. And what made it simple for us, I guess, was having, one, being attached to an institution that had a pretty wide, we have Epic for our electronic medical record system. So, and then just being creative with how you create, how you get that across. So basically, how we've made it happen is each one of the school districts has their own, medical record number, and then through that, we can, put the orders, and then Cook Children's, they go to Cook Children's and to their pharmacy, and then all of that gets coordinated to be distributed through the school. So, honestly, I was nervous, learning about this at first, but I think that once and it doesn't require that large, if you're starting small, you don't, if you're talking about a smaller school district or rural school district, you could still do paper depending on what your grant funding or, where all your monies are coming from. But, I think that we have such a great collaborative group that it was not as overwhelming as it could have been.
So it sounds like partnering with larger institutions can be helpful. It'd be interesting probably in the future to figure out what we can do for those smaller smaller school districts, to partner with them as well, and make this more of a collaborative effort to make asthma better for children in this entire state of Texas. I also wanted to include one more thing. Charlie gave us a link for the American Lung Association with teaching about albuterol usage, so you can click on that. And then in the future, of course, we'll provide after this some additional information regarding Asthma 411 and what they have available as well for all those that are registered. But I am so sorry, we are coming to the end of the hour. We are over time. I think this was absolutely amazing. And I want to thank all of our panelists for all of their extremely hard work, especially Dr. Alsop for everything that she's done. And she's really been the pioneer of this and piloting this very, very enthusiastically. It's been amazing. If you can just also click on that link that Charlie provided, if you're a registrant, if you want more information, if you want to be more plugged into the system, if you want to be part of our Texas Stock Albuterol Task Force as we work on making this legislation better and work on education, that would be amazing. Leslie, since you're the pilot of this, is there anything else you would like to say in closing?
I really want to thank everyone who has made this possible. All of our speakers who have joined us today from across Texas and nationally. I want to give a special shout out to Dr. Sexton, who has joined us from her clinic. And we really they are absolutely fabulous, as the Asthma 411 Medical Advisory Council is, and they have made great strides in removing barriers along with the consortium. So thank you all so much. I am going to bring up a last slide here for us all, and thank everybody one more time. Thank you for attending. If you would like more information about the resources we have for implementing unassigned albuterol in Texas with the framework to improve asthma outcomes, you can either email us here at UNTL Science Center or check out the website. It's all freely available. And that is my email as well. Thank you to everyone. Please take up Charlie's wonderful offer of his chat and of that link, and we will look forward to partnering with many of you and helping children be safe at school, breathe easy, and learn better. Thank you all.